Welcome to the Westin MCAT podcast with your hosts, Eric Olson
and Jayden Garcia.
Okay, welcome back to the Westin MCAT podcast. I am host number one today, Eric. I'm here with my friend Jayden, my co-host, and we're excited to be with y'all today. Jayden, how are things going? What have you been up to the last week or two? Seems like it's been a minute since we talked.
Yeah, things are good, man. Currently on vacation, which is kind of a coveted time during this training process. So, actually getting to sleep in till 7 is pretty phenomenal.
Yeah.
Otherwise, I've now kind of switched services. I'm no longer doing pediatrics. I've been doing head and neck cancer surgery, which has been a lot of fun. Those patients are really, really sick and are really grateful for the work we do. And so spending time with them in the operating room and in clinic has been super rewarding. And we've been doing some skin cancer work, Eric. So, it's kind of our fields crossing over quite a bit.
I love it. I think I have to ask. I think people probably want to know, at least I want to know. You say waking up at 7, like that's such a sleeping in for you.
Yeah.
I feel like for me, the earlier rotations I've been on, I've had to be in it. Well, the earliest I really had to be in consistently was when I was in the ICU this year, at least as a resident. As a medical student, when I was on surgery rotations, it was earlier, but 6 a.m. consistently in the ICU.
Mm-hmm.
So waking up at like between 5 and 5:15, kind of depending on what traffic is looking like and things like that. But what is early for you? What's the norm?
I'd say the norm is setting my alarm somewhere in the early 4s is kind of normal for me. Sleeping
Sounds truly awful.
Sleeping in while I'm working in the hospital would feel like setting my alarm somewhere in the early 5s. That'd feel like sleeping in to me. And then there's occasions where the alarm gets set in the early or like mid 3s, like 3:30. Those are painful. I think every minute earlier than like 5 a.m. is like an exponential difference in how I feel. But yeah, that's pretty typical early 4s.
I don't feel like we should dwell on this, but I'm really interested to know, like, why are you getting up in the 3s? Like, what are you having to do between 3 a.m. and presumably surgery doesn't start till like 7, so that's like 3+ hours pre-surgery. I don't even know, what are you doing?
And I think part of this is people, and our students will probably understand at whatever level, people have different preferences on how much they want to push their alarm to get to whatever they need to do. So I'm one who does like to have a little bit more of a calm morning instead of really push that alarm. So you probably could get away doing it in the late 3s. But essentially, if I'm waking up that early, that means there's a lot of patients on our patient census, probably north of 20 plus. And I usually that means I probably have to be in the hospital an hour to an hour and a half before rounds start, which means if we're waking up that early, rounds are probably at 5:30, which means I need to be at the hospital around 4 so that I could get basically everything ready for the day as the bottom of the totem pole, if you will. Printing out lists, making sure I grab all the numbers for how patients did overnight, grabbing all the supplies. ENT, our patients have a lot of needs for wound care and supplies. And that could be kind of taxing if we're going to change a trach, if we're going to unbandage somebody who has an arm or a leg that we've operated on, for our reconstruction sites.
Yeah.
So it's just a lot of work,
You are, I'm just, I don't want to say, I certainly wouldn't say envious, but I'm proud of you. It's hard work. I couldn't do it. And I'm not doing
that,
it.
Man.
So
I think you could. It's a decision that I made that I have to live with, but I'm encouraged now that intern year is almost over for the both of us.
I was going to say, you got about 2-3 weeks. It's going to get a little better. And you won't be quite the lowest man on the totem pole anymore.
Right, man.
which will be
And I
good.
don't want to dwell either, but it sounds like you're moving and you're right in that
Yeah.
phase, moving over to Alabama. That's exciting.
Yep. Doing a dermatology rotation now, which is a good way to lead into dermatology residency for real.
Yeah.
And yeah, just my house is full of boxes and trying to coordinate the moving truck and all that stuff. So I've been working on like onboarding for my new position, and you know, I don't know. I wish
Our
that I could have just done one onboarding for residency, and now I'm doing round two, which has taken a couple of days of trainings and things like that.
our
But
listeners will
it's what it is.
soon find out at some point like how burdensome the onboarding process for a hospital system is. It's awful.
Yeah, even as a medical
Terrible.
student, you're doing the same
Totally.
things, and they have all these certifications they have to keep up to date, and it's a lot of regulation that makes getting a new job just harder than it otherwise would need to be.
Totally.
But it's part of the privilege of being able to treat patients, and it is, it's sensitive, and it's what is the term, like high fidelity, like
Yeah.
we have to stick to protocols like more so than in lots of other industries. I think it's often compared to like aeronautics, and like when you get on an airplane and they have like their checklists, because if anything goes
Mhm.
wrong, it's a big deal.
Big
And
deal.
kind of similar with medicine, like the mistakes can have serious consequences. But anyway, we're kind of going off topic here, but we wanted to talk today a little bit about the immune system. And I think, for me, it's funny. I worked in an immunology lab in undergrad, and I just never like, I don't feel like I ever got good at it.
Mm.
Not the lab stuff, like I figured out how to work in a lab, but just immunology, I think there are like a lot of little things. And once you start getting into like pathways of how cytokines and receptors interact and things like that, it can be really overwhelming. And so we wanted to talk today about some of the important points that are needed for the MCAT, because we were talking about it, and it's easy to get lost in the weeds. But Jayden, what do you think? Why is the immune system so important?
Mhm.
Where are we gonna see it? Things like that. Give us some basic overview.
Yeah, immunology is tough. I mean, my professors in med school always talked about how when they were med students, there was like a pamphlet that was the extent of immunology at the time, and now there are textbooks upon textbooks upon textbooks about the immune system. It continues to be an area of significant research. It's been the focus of the physiology Nobel Prize for multiple years in a row. Most of those who are winning the prize often have immunology backgrounds. And I do think it's important on our show today that we kind of discuss what is more relevant for our listeners who are taking the MCAT versus not, because what's difficult is a lot of even MCAT textbooks will kind of include the whole kitchen sink, and that's not exactly what the test authors, if you will, are looking for. Um, and another point about the immune system before we dive into the nitty gritty is I think the immune system's tough for MCAT learners because we often talk about this idea of understanding principles and not just rote memorization, but unfortunately immunology carries a little bit more of that rote memorization, that there are certain facts and things you have to know, or things get tricky very quickly. And so thinking of things that you don't need to know that I think is pretty relevant for our discussion. There are lots of receptor names when it comes to immunology. Cells have lots of receptors that are expressed from genes, and you can get into the alphabet soup of what those are. And I would say those are a pretty minimal yield topic. So T cells, B cells, for example, have lots of different receptors. T cell
Yeah.
receptors, B cell receptors. And as a pre-med listening to this, I wouldn't focus on those. I would try and understand how immune cells talk to each other in a big overview way, but getting into memorizing, what each cell receptor is, the name, because it's usually associated with some number, is probably low yield. Secondly, a part of the humoral immune system, we'll get into all of this. There's lots of different antibody types, and I've seen a lot of students over the years really strike up a lot of anxiety over the different types. And while this is a topic that you'll explore quite a bit in medical school, at least in your first or second year, I don't think the MCAT really tests this all that much as far as, the different chains on an immunoglobulin and whatnot. So it may be important to kind of understand what each immunoglobulin looks like. Knowing the nitty gritty of what makes them different may not be helpful. Now, kind of thinking through the big picture of how somebody maybe gets an infection and when certain immunoglobulins are highest in certain phases is maybe a higher yield topic. Still don't think it's going to be tested all that much, but it's probably a little bit more important than some of the other things that I've mentioned. Eric, just to toss it back to you, is there anything that I've missed that you think any immunology med students or pre-meds can kind of go down that pathway, spend a lot of time, but it's not actually that useful?
No, I mean, honestly, I appreciate what you're saying. I agree. I know I spent a lot of time, and part of it was because I had some classes where we talked about, IgGs and the different chains and all that stuff. And it is daunting. But that stuff's not coming up on the MCAT. And I think you're highlighting like an overarching theme of the MCAT, which is certainly true for immunology. It's true in many other fields as well, which is that there's so much to know. But at the end of the day, like the MCAT is only going to test you up to a point on detail. And they want you to have an overview of how these things work, like you're saying. I love what you said. Understand a little bit about how cells talk to each other in the immune system. But there is a lot of detail that they're not going to test you on. And I think as someone who, as the two of us as individuals who have like coached lots of people and tutored people in preparing for the MCAT, it's easy to say like, this is what you need to know. This is not important, right? And it's harder as a student, someone who's preparing to take the test for the first time, to say, I don't know where to draw the line, like what is important and what's not. And so we're going to try to talk about a few of those things, but I think the principle that I want to emphasize and reinforce that you stated, Jayden, is that you need to know the basics and you need to have the overview. But ultimately, like when we get down into the real nitty-gritty details, if they want you to know something, a lot of times it's going to show up in the passage. You need the baseline level of understanding so that you can read a passage and understand what's going on. But if they're going to ask you about like this T cell receptor versus that, they're probably going to have it in the passage, as opposed to like in a standalone question, if that makes sense. So it is hard. It is hard to know like where do I draw the line of studying appropriately and learning the things I need to know versus like digging too deep. And at the end of the day, like that information is available to you through the AAMC. They have a web page or pamphlet, I don't recall, but it's called, like what's on the MCAT exam. And they have a list of all these of every topic that could be tested on the MCAT. And they don't tell you all the details, but they'll say, oh, here's the immune system, and we're going to talk about T cells and we're going to talk about B cells. So you need to know some of those topics. But ultimately, I think we can spend too much time on the immune system or any other topic, and you have to be reasonable in learning like the points that are important versus stressing yourself out about the things that are maybe not so important. So Jayden, what do you think about important things that we do need to know? Let's walk through a couple of these things
Right.
and give some specifics.
So I think, the immune system, immunology is a discipline with lots of buckets. And what I mean by that is there's a lot of branching points that are important to understand. And I think if you understand these different branching points and a little bit about each stop, you're on your way to getting virtually every question correct, as long as you can employ some of these other techniques we've talked about when it comes to strategy. So to begin with, there's an innate system and there's an adaptive system. And those are really the two broad categories of immune system defense. And in the innate system, big picture here, these are things that we're just born with, things that are not very specific to fighting off. And in that group, there are a host of cells that, again, we're born with. And the caveat is, over time, in the first couple of years of life, these may not be super robust, but they are present. And as kids get up to the age of 4, for example, this is why kiddos get really, really sick pretty quickly, is they are lacking in probably both of these camps, the innate system that's non-specific and the adaptive system, which is fairly specific to whatever antigen or offender is nearby. So in the innate system, something I'd like our students to remember is if there is a cell that ends with PHIL, P-H-I-L, that is going to be in the innate system, right? So I'm just going to throw out a couple that you need to know. Neutrophil, arguably the most important innate immune system cell. It really doesn't care what's around. It's going to attempt to try and solve the problem if there's an antigen around. It is the most abundant of the innate cells. I'd say it's the most abundant of any cell, white blood cell, in our body, typically making up 50 to 75%. So you can imagine when Eric and I are in the hospital and we see a patient who either has a dermatologic problem or an ENT problem, and their absolute neutrophil count, the ANC, as you will come to know it, is incredibly low, less than 500, we have a significant problem, because virtually any sort of infection this person deals with, they're going to have a really hard time out in the response with no neutrophils around. So I just wanted to take it aside for neutrophils because it's probably the most important cell we could talk about today. Secondly, basophils, eosinophils. Eric, am I missing any other phils?
I don't think you're missing any phils.
The 3 phils really are make up the innate immune system. Natural killer cells as well. These are kind of hard to understand, and this is where I wouldn't get into the nitty-gritty. Natural killer cells kind of walk around and try and find antigens that are causing problems. But there is a little bit of a crossover, as we'll get to, on the adaptive side. If there is an adaptive response taking place, there are cells that can really heighten the response of natural killer cells around. And so natural killer cells do, I think, overall belong in the innate bucket, because they're not looking for a particular thing, but they can be heightened by adaptive immune response. Is that something you would agree with, Eric?
Yeah, absolutely. I would agree. I would just really quickly say, because they're my favorite immune cell, which I didn't ever think I would have a favorite immune cell, but I do, and it's the eosinophil. So I would just say, the basophils release histamine, and so they can be implicated in like allergy and like anaphylactic response and hives and things like that. And then eosinophils similarly can show up both with like allergic conditions, things like that, as well as parasites. I don't think that's super high yield to know, but I think it may come up. It may be helpful just to know what they do. So as Jayden said, neutrophils being like kind of the workhorse of the innate immune system, that they like phagocytose kind of just anything that's around. When you see like pus in a wound or even in an acne bump, the pus is like made up of neutrophils, dead neutrophils that have phagocytosed some sort of bacterial product or something like that. So there's, as Jayden said, I say this just to illustrate, there are so many neutrophils. There's just a ton of them. And then eosinophils and basophils, again, a little bit more specialized, and can show up in some of these other conditions. But sorry, Jayden, I'll let you
that was excellent.
go ahead with.
Um, I guess to
It
add
may
on
it may
that,
be go
oh,
ahead, go ahead.
I was just going to say, like, we talked a lot about how the neutrophils are the most abundant cell, and I think it's important for students to know that the basophils and eosinophils that we just referenced are so small in number in comparison. So when we do get, you know, a complete blood count and we see elevation in those things, it can kind of sound the alarm to either, to Eric's point, an allergic process going on, right? If somebody has severe anaphylaxis, the basophils are going to be higher than they would in a normal person. If somebody's having, a, a parasitic infection, we'd expect those to be higher. So these are things in the hospital that people are checking, and the reason why the MCAT wants you to understand their basic functions. Sorry, Eric, what were you going to say?
No, I was just gonna say I think this is a good like a good time to kind of transition. And I will say, like, innate immune system, like there are lots of things that we also include, and I'll, because skin, and I'm a skin doctor, like skin is part of the
Yeah.
innate immune system, right? Like it keeps out all these sorts of pathogens. Like when your skin barrier is compromised, it can cause problems for you. You can get more frequent infections and things like that, as well as, like, there's like cilia that are pushing mucus out of your respiratory tract, which I think would be characterized as innate immune system. Like it's helping you to fight off infection without being specific to any one thing. Um, and so, like, like the gastric acid that's in your stomach would be characterized maybe as part of the innate immune system because it's killing bacteria that might otherwise cause you issue, but it's not like in response to a specific pathogen, right? So that's, again, when we talk about innate immune system, it's like things that are there, things that are going to be responding. They're not like necessarily only going to respond when it's this sort of bacteria that's causing a problem, or this particular virus. And that's where we see, and I was going to say, I think this is a good time to kind of cross over between the innate and adaptive immune system in what I would say is like the crossover cells, particularly are the dendritic cells and the macrophages. And I think
Mhm.
maybe macrophages, and correct me if I'm wrong, maybe macrophages fit a little bit more on the innate side, whereas
Playback. Yeah.
dendritic cells are also referred to as professional antigen presenting cells. And so this antigen presentation is where we see like the basis of talk between different sides of the immune system. And Jayden, you said, learn how the cells talk to each other. And I think there's a lot to that. It's not all necessary to know for the MCAT, but this is one that I would certainly recommend being familiar with, and that is that macrophages are kind of or dendritic cells in particular are kind of the crossover between the innate and acquired immune system. And the way that that
Mhm.
works is that a macrophage, similar to a neutrophil, really, will kind of respond to any sort of bacteria or foreign material that they find offensive, and they'll phagocytose that, which means they'll like effectively eat that particle, whatever it is. And the way that then there's crossover between the innate and acquired immune system is that a macrophage will kind of digest up the parts of that bacteria or whatever it is that they phagocytosed, and they'll take a piece of it in their little cell hand and they'll hold it up to all of the other cells in the immune system and say, "Hey, does anyone recognize this? Does anyone know what this is? Because I ate it and like I think it might be a problem." And then all of the cells of the adaptive immune system, so B cells and T cells in particular, can then like visualize, or really what happens is like there's a dendritic cell hand and then there's a B cell hand, and they'll kind of like come together at this antigen spot. And if anyone recognizes it from the adaptive immune system, the B cells and T cells, then they can proliferate and mount an immune response. And we'll get in a little bit to kind of what differences there are between B cell immune responses and T cell immune responses. But Jayden, do you have anything to add about kind of how dendritic cells and macrophages work?
So I just wanted to emphasize that if there's maybe one topic today that you're most likely to see on your tests, it's this idea of antigen presentation. So knowing the cells that Eric pointed out do this sort of antigen presentation and understanding the big picture of how it's done is super high yield. So if you have to rewind this and listen to that again, it's really, really important. I can say firsthand and also secondhand from the students I've coached, this is where it comes up the most. Immunology is understanding this exact thing. They do also like to test the differences between MHC, like major histocompatibility complex, I think is the term.
Yeah.
But
Yep.
MHC 1 versus 2, and it has exactly everything to do with what Eric just said. There are certain cells that are able to munch something up, present it, and start a cascade of events that really heighten our immune system. And we talked about the cells, but the MHC complex is exactly where that munched up protein goes up on the silver platter for other cells to respond to.
Yeah, it's
Now,
the cell hand that they're using to
exactly,
present. Yeah.
exactly. And MHC1, correct me if I'm wrong, Eric, every cell in our body should have that receptor. And
Every nucleated cell, yes. So with
correct,
the exception of like red blood cells, I think is the one that I can think of.
important
But yeah,
distinction there. Mm-hmm.
every nucleated cell has MHC1, and so they can present certain antigens on their surface for recognition by T cells.
By T cells. And we'll tie that in, right? Because T cells really are the cell in cell-mediated immunity. So if a cell is sick because it's recognized there's a virus, there's a bacteria, you name it, and it's showing on its MHC class 1 that there's something going on, it may strike up a response by a T cell to say, hey, I need to go before this gets out of hand. The difference is MHC class 2 is only on some of these special professional antigen presenting cells that we've discussed.
So
and
macrophages, dendritic cells, and B cells as
B cells as well. Correct.
B cells as well have this MHC class 2 that they can present these bacterial products. Sorry for interrupting. Go ahead.
No, that's perfect. I mean, that's an important distinction. That's what makes it an antigen presenting cell, is it has this separate MHC class 2 protein that can show other cells what's going on.
Yeah.
And I could see an MCAT question in your future where certain cells are discussed and they have you choose, which of the following would, a certain cell like a B cell have. And they may try and trick you by saying, oh, is it just MHC class 2? Or is it MHC class 1 as well? Or both, And it's important to recognize, again, that all cells, even the antigen presenting cells, have MHC class 1, but they also have MHC class 2.
I love that. I love that example question, because they have questions like that. Which one of these is it? Is it A or is it B or is it both?
Both.
And that's a perfect example. So kind of putting it together, we've been skirting around these ideas. So B cells, macrophages, dendritic cells, these three types of cells can phagocytose a bacterial product and use MHC class 2, major histocompatibility complex 2, to present those antigens. When we talk about antigens, it's basically just a protein or like a part of a bacteria or whatever. And those parts can then be recognized by other cells to mount an immune response. These are usually bacterial parts, right? That they're phagocytosing some bacteria, because we generally don't phagocytose our own cells. Now, that in comparison to MHC class 1, which, as Jayden said, is present on all cells, this is usually presenting viral products. Because if you think about how bacteria works versus how a virus works, a bacteria is just like invading your system. It's like utilizing resources. It's going to like grow and proliferate outside of cells, right? Like it doesn't invade inside of a cell. In contrast to a virus, which, injects its material into a cell and then utilizes the cellular machinery to replicate itself, and then like lyses that cell to produce more virus that can then go out and infect other cells. So when you have a viral infection, it's like infecting individual human cells that you have. And when a virus is present inside of a cell, then those viral particles are getting picked up and presented on MHC class 1 in any given cell, right? Like it could be a B cell, or it could be, a stomach cell, or it could be, a cell in the lungs, or whatever the case may be. And when, again, a T cell then will interact with MHC class 1 and recognize those viral antigens, then a T cell can mount, as Jayden said, a cell-mediated response. And so let's talk a little bit about B cells versus T cells, but I think the point leading into this that I want to emphasize again is that B cells are mounting a humoral response, usually in response to a bacterial particle, whereas T cells will mount a cell-mediated response, often in response to a viral infection. There are exceptions to these things, but especially for the MCAT, this is kind of how I would categorize it. It's like T cells are viruses, MHC class 1. B cells are bacteria or fighting bacteria, and that's MHC class 2. But Jayden, either one, if you want to talk about T cells, if you want to talk about B cells, I'll talk about the other one, and we'll talk about kind of like how that response is mounted and what that looks like.
Perfect. And can't state this enough and clarify this enough. We are now discussing the adaptive immune response. So we went over innate. All of these kind of pathways that Eric and I are discussing fall into the adaptive immune response. And I'll talk about B cells. As Eric pointed out, bacterial antigens can really get B cells up and replicating. Typically, because bacteria are extracellular, as Eric was describing, B cells' main job is to produce antibodies. That is what we mean by humoral response, is that we're making antibodies that will stick to bacteria or other antigens that need to be addressed. And that antibody may cause other cells to come eat whatever bacteria we're talking about. It could itself cause damage to the bacteria. It could set off what we call complement, which is a host of other proteins that recognize the antibody attached to this bacteria. And in the end, we'll poke a whole bunch of holes into it to cause it to die. So just knowing that B cells' main job is to produce antibodies, those antibodies can impact this bacteria in many different ways, is probably really key. And antibody, we're all born with B cells, but they're all what we call in the naive state. They have not been activated until some particular bacteria comes along so that an antigen-presenting cell can make a naive B cell aware of what's happening. And the B cell will then start making antibodies and then will actually transform and replicate into a plasma cell. And a plasma cell is an antibody machine gun. Its main job is to kind of localize, maybe not in the bone marrow where most of these cells live, but more toward the tissues that are affected and start producing massive amounts of antibodies. And in the end, a B cell can then transform into a cell that it's going to last a long time in the system.
A memory B cell.
Correct. A memory B cell that, when engaged again, will be able to even double, triple, quadruple its response. And so in understanding the main phases of naive, gets activated, plasma cells will be created for the infection that's currently happening. And then in the end, we want memory cells so that we can remember if that antigen ever comes back, we'll be ready with our army of B cells for that specific antigen.
Yeah, beautiful. I'll just add, as long as we're talking about B cells are developed in the bone marrow. I don't know if that's why we call them B cells. I think probably actually it might be. But B cells are bone marrow. We'll get into T cells, which are generated in the bone marrow, but are trained and developed in the thymus. And the other thing I'll say about B cells, and you kind of touched on this, but like we talked about innate and adaptive immunity, right? These are like two sides of the immune system. And this is what you were talking about when we first started dating about like these branching points in the immune system. Within innate immunity, I would say there are like physical factors, which is like skin barrier and like gastric acid. And then there are cell barriers, which are like the neutrophils, the eosinophils, the basophils. Now we're talking about adaptive immune system. And I think, the branch point is like humoral immunity and cell mediated immunity. And as you said, we're talking about B cells, we're talking about antibodies. This is humoral immunity. And I'll just say, like, just because I think it's kind of fun, although I think it doesn't super matter, because you think of it in contrast with cell-mediated immunity, which is obviously like a cell killing another cell, or maybe not obviously, but that's what it is. But like humoral immunity, these antibodies are released into the bloodstream, right? And I love the antibody machine gun. I hadn't thought of it that way, but that's totally on spot on. But like humoral, what does the humor mean? Like, if we think about the origins of medicine and like some of the early thoughts of what caused disease and things like that, they talked about the different humors in our body, how there's like the black bile and the yellow bile and the red blood, and I don't know what the other one was or something like that. But the idea is being like, these are these different fluids that are like flowing through our body, and when they get messed up, then like that's what causes disease. And so when you think about humoral immunity, like what are we talking about? We're talking about bloodstream mediated immunity, that you have these antibodies that are produced and released into the bloodstream, and those then go and like find different things to attach to that are causing disease and causing problems. Cool. Let's talk about T cells really quick, unless you have anything to tack onto that, Jayden.
No, that was excellent, Eric. Nothing to tackle.
I thought you did a great. That was a perfect overview. As far as T cells go, so again, they work a little bit differently. They principally are used to treat viral infections in the body. There are three types of T cells, maybe two that are more important than the other. The least important is called a regulatory T cell. Or a suppressive T cell. And these are T cells that are used to kind of like damp down the immune response and like calm things down when things get crazy. The two more important are killer T cells and helper T cells. This is one of those areas that I think may be tested and may not be tested. Jayden, I'd be interested to hear your thought, but helper T cells have one receptor on them. It's called CD4. And killer T cells have a different receptor called CD8. And so sometimes, again, I think it's possible for this to show up in the MCAT. When we talk about CD4 T cells, that's a helper T cell. When we talk about CD8 T cells, those are killer T cells. And they have kind of two different functions. The helper T cell, it's kind of the opposite of the regulatory T cell or the suppressive T cell, in that it kind of ramps up the immune system. It gets other cells excited to fight infection. It's like a motivational speaker kind of. And helper T cells are actually involved in the humoral immune response as well. When B cells are activated, they can recruit these CD4 helper T cells to kind of get things revved up and get things moving. So those CD4 helper T cells are involved in both the cell-mediated and the humoral immune response. The CD8 T cells are like cells that kill infected cells that kill infected human cells, I should say. And so, we talked briefly, I mentioned that these T cells are kind of born in the bone marrow and then developed in the thymus. So what happens in the thymus is that these T cells, these CD8 T cells, are presented with all these, and CD4 cells, I should say as well, but T cells are presented with all these different self-antigens, like normal proteins and things that are found on cell surface throughout the body. And if they react to the body itself, to like normal proteins and cells and things, then they'll be destroyed, because that, would cause kind of autoimmune disease if they were left in the body to react to the body itself. But all the T cells that don't react to kind of native proteins will be left in the body. And the reason for that is that the body's saying, if we want to test these T cells against everything that's normal, and if they don't, then they'll only react if something foreign comes into this body. And we want to keep those guys around because if something foreign presents inside the body, then we want to be able to kill those cells that are infected by foreign substance. Mm-hmm. And so those T cells then will, go to different sites in the body and go to the lymph nodes and things. And when they see a viral antigen or a viral protein that's on a cell, which again would indicate that there's a viral infection going on in that cell, then those T cells are activated, and the killer T cells or the CD8 positive cells can then go and like actively kill and like exterminate these infected cells. It is, I don't know. It's just, I find it a fascinating process. When I was, after my junior year, I think, of college, when I was like in the thick of applying to medical school, and I did this internship at a laboratory where we were working on like genetic modification of T cells. And some of you may know this. This is not going to be tested on the MCAT by any means, but for the sake of interest, there are these like genetically engineered cells that are kind of being used in some cases and are certainly in development for treatment of malignancy or treatment of cancer, called CAR T cells, chimeric antigen receptor T cells. And again, a T cell is a cell that is designed to kill infected or diseased human cells. And so the way that a CAR T cell works is that we like design the receptor itself. So we design what it's reactive to. And, we can work on like the configuration of what the receptor looks like to respond to specific antigens. And so and this will be of interest to you, Jayden. I don't know if we talked about this before, but the product that we were working on, the T cell receptor that we were working on, was in response to human papillomavirus antigens. And for those of you that don't know, HPV is a virus that causes cancer. It's implicated in cervical cancer. It's also implicated in a significant proportion of head and neck cancers. And so we were looking at, better ways to treat head and neck cancer. And so we were, finding receptor arrangements that had a high affinity for these viral proteins from HPV. And then, we were in like rat and mouse studies at the time, but we would like grow these HPV positive tumors in mice, and then we would inject these populations of genetically modified T cells into them, so that those receptors could find the HPV infected cells, which were the tumor cells, and destroy them all. And it's like a very burgeoning and expanding area of research right now. This was like 6 years ago at this point, so I don't know really where that research went. I haven't kept too much up with it, but I don't know, Jayden, are you familiar with that at all? Anyway, the reason I bring it up is because I think it's a fascinating application of adaptive immunity and like our ability to engineer adaptive immune cells in these kind of novel ways, right? Like they're traditionally used just to fight viruses, and now we're kind of using them to try to find antigens on cancer cells, so that we can attack cancers in that fashion. It's pretty cool stuff, I think.
That's super cool. And I think hopefully our students are starting to understand the endless applications to what we're discussing, and why immunology is such a growing field, because any one of these mechanisms can go wrong in this process and cause disease states. Similarly to your point, Eric, these same pathways can be manipulated to treat disease as well. And I think with the T cells, if the students understand that this process, if ramped up too much, causes autoimmunity, and if knocked down too much, or it's missing, right? Congenitally, people can be born without immune systems or have variations in their T cell, and similarly to HIV patients who impact their CD4 cells. If this process is not happening, you can get malignancy, cancer, or you can get horrible infections that are just can't be treated, right? People who have end-stage HIV, which we call AIDS, their CD4 counts are so terrible that they can't mount a response to hardly anything. So they die of things that any person with an immune system normally would fight off no problem. So just amazing applications.
And to your point, I think if I had heard what you just said, that an AIDS patient would die from things that a normal, a healthy person would fight off with no problem, and I'm thinking like, oh, like, the common cold, or I don't know, like a small skin infection. But these AIDS patients, their immune system is so devastated that they're getting infections from things that you've never heard of before.
Right.
And I don't mean that derogatorily, but like things that I just learned about 2 years ago, because they're things that people with a normal immune system, or even with a severely limited immune system, but still an intact immune system, can fight off. Whereas an AIDS patient just has no reserve to be able to fight off these infections. And I think it can be an important point as well, or at least a learning point, that, as you said, in an AIDS patient or an HIV patient, the CD4 count is being affected, and those are those helper T cells. And if we remember, those are involved both in humoral immunity of fighting off bacterial infections and cell-mediated immunity of fighting off viral infections. And as you could imagine, then these patients with AIDS are dying from both bacterial infections as well as viral infections, because they can't, the CD4 helper T cells are kind of integral to both of these systems. And so when those cells aren't working appropriately, then, uh, those patients are being infected kind of on every side by any sort of pathogen that might come along. There is one other thing I wanted to talk about briefly, Jayden, as far as the immune system goes, and that is kind of what are the different tissues that are part of the immune system. So like lymph nodes, thymus, we talked about briefly, bone marrow, and
Tonsils.
spleen. What?
Tonsils.
Tonsils. Oh yeah, tell us about tonsils. I thought you said muscles, and I was like,
Muscles.
you're about to teach me something that I don't know if that's involved in the immune system. Yeah, tell us about tonsils and kind of what an MCAT taker would need to know.
No, probably not much. I wish I could,
Probably not too much, huh?
I wish I could dive into why tonsils are important for you to know for the MCAT, but I do think Eric pointed out the main tissues involved, and I think there's even a phrase, remind me, Eric, of like primary organ, secondary organ, lymphoid tissue. I think the bone marrow and thymus are considered like the primary tissues, and I think some of these other ones that Eric mentioned, tonsils, lymph nodes, lymph vessels, spleen, these are secondary organs where after these cells mature, they can go out to these various sites. So Eric brought up that T cells mature in the thymus, which is actually gone by the age of like 5 or 6 or something like that. It atrophies quite a bit. And again, a little bit of a tie into HIV. This is why it's so difficult to treat HIV, because once those counts are impacted, it's really hard to make a big difference again, because the thymus is no longer there. I've actually taken out a lot of thymus when I do thyroid surgery. There's a little bit of thymus tissue that needs to be taken, and it's just tiny, tiny, tiny. But if you were to look at like a 2-year-old, it's really big.
Yeah.
Sorry, that was an aside, but I just wanted to point out these cells grow up in either the bone marrow or the thymus, and then can go out to these various tissues, these secondary tissues like the spleen or the lymph nodes or the tonsils or the adenoids. These are all areas that house a lot of different cells that we've discussed.
Yeah, I mean, when we talk about the innate immune system, neutrophils, eosinophils, they're kind of just circulating in the blood for the most part, and kind of going where they get called to. They can live in the tissues as well. But these kind of secondary lymphatic centers is principally where lymphocytes live. When we say lymphocytes, we mean B cells and T cells. So they'll develop in the bone marrow and in the thymus, and then they'll kind of go out to these, like sentinel positions to wait, and they just kind of watch. They're like lookouts, and eventually, a dendritic cell might come along that has an antigen to present, and then they'll get activated. So I just want to overview, because I think, as we said at the beginning, there's a lot to know. There's more to know. There's more to learn than you need to know for the MCAT, I think is a big takeaway. So like, learn the important points, use your resources, use this podcast, use the other things that are out there to determine what's important and what's not, because you can really get into the weeds on this. But I think these branch points are important. It's important to have this overview and this conceptual understanding of kind of these branching points. And so, as Jayden said at the beginning, there's innate and there's adaptive. We talked about innate. I won't touch on it now. But within the adaptive immune system, there's humoral and there's cell-mediated immunity. The humoral immunity involves those B cells, which can then differentiate once they're activated into memory B cells, which are kind of the long-standing B cells that can help you to mount a response in the future if you're secondarily infected or infected again in the future with a similar pathogen. And then the machine gun what do we call those, Jayden?
The plasma cells.
The plasma cells. Yeah. I'm just gonna call them machine gun cells for now. And then within the T cell response or the cell-mediated immunity, we have those CD4 helper T cells, which help to mount the immune response, as well as the CD8 killer T cells. And again, those CD8 killer T cells will respond to major histocompatibility complex or MHC class 1, whereas the B cells will respond to MHC class 2, which is only found on fellow B cells, dendritic cells, and macrophages. So, hopefully that provides a decent overview. I think if you know those things, that's going to get you halfway there. And then focusing on some of the details we've talked about will be helpful to get you the rest of the way. Jim, do you have anything else to add before we close out?
No, I think we spent some time on clinical applications that are not just fun. I think on this podcast, we like to highlight some areas where all of this becomes useful to our learners at some point. But I actually do think our clinical connections do frequently come up. We talked about autoimmunity and cancer. These are two topics that do come up on the MCAT and are in relation to the immune system, and it is totally fair game for them to bring that in. They won't expect you to know every nuanced thing about how that happens, but it would not be uncommon for you to get an article or a scientific paper that's on one of your passages that tie the immune system to cancer. That's not unforeseen, So I would take some of these clinical applications to heart, be able to think through this pathway that Eric so eloquently described here at the end of how cancer can happen from an aberrancy in the immune system, or how autoimmunity can happen, or how severe infection can happen. And I think just thinking big overarching view of those clinical applications, you're going to be prepared for what you might see.
Beautiful. Well, that's all we have on immunity. There's certainly more to know, but we wish you all the best of luck, and especially as some of you are preparing now to get ready and take this test in the next few weeks. We hope that we hope for the best, and we hope your studying has prepared you well. And we'll leave it at that until next time.